Hello again, it's Dr. Jaffer. Today I'll discuss the last topic throughout what we talked about, which was gingiva, and our last topic is gingival recession. So we are talking today about this subject. Throughout the definition, we know that from the name, recession refers to the location of gingiva, not its condition. And gingival recession is a common finding. The prevalence, extent, and severity of the gingival recession increase with age and is more prevalent in males. And by definition, recession is the exposure of the root surface by an apical shift in the position of gingiva. And to understand recession, it helps to distinguish between two terms, the actual and apparent position. The actual position is from cemento-enamel junction to the most apical part of the junctional epithelium, while the apparent position is what we see clinically, just the part of the recession, the part of the visible root surface. And this is not the actual recession actually. This is the apparent one. Because we have some of the root surfaces here, some of the recession here is covered by the pocket wall. And this root surface is denuded throughout the disease. So this should be also included in the recession, in the measurement of the recession. Because the severity of the recession is determined by the actual position of gingiva, not the apparent position. So this is an important point while you define the recession. Regarding the classification, we have Miller classification, which is the most popular one, and we have Kuhlmann-Massati, which is most preferably used during research. But the Miller classification is the easiest one as most popular. We have class 1 when we have a recession not extending to the mucogingival junction and there is no any interdental bone loss or gingival loss. While in class 2, the recession may reach the mucogingival junction or it may reach beyond the mucogingival junction, but there is no interdental bone loss and soft tissue loss. While in case of class 3, the recession extends beyond or to the mucogingival junction and there is some interdental area of attachment loss, including the soft tissue and bone. While in class 4, there is a complete loss of bone and soft tissue, and the soft tissue mostly beyond the mucogingival junction, and this case is hopeless or it can't be restored in this case. So this is regarding the classification. We have 11 possible causes, or maybe 12 actually, of the gingival recession. One of them is periodontal disease. We know that the invasion of bacteria will cause the rupture of periodontal ligaments and loss of periodontal bone, and this may lead to a gingival recession. Another cause is aging process. We said that the gingival recession increases with age, and the incidence varies from 8% in children to 100% after 50 years of age. This has led some investigators to assume that the recession may be a physiological process related to aging. However, no convincing evidence has been presented for a physiological shift of the gingival attachment. But the most important and the most powerful evidence suggests that a gradual apical shift is more likely the result of the cumulative effect of minor pathological involvement and repeated minor direct trauma to the gingiva. So the usage, let us to say like that, the usage of the teeth and the gingiva, it will make it susceptible to minor trauma throughout years by years, some of them by habit, some of them throughout using toothbrushing. There is minor trauma continuously, and with the presence of bacteria, this will make the possibility higher of presenting gingival recession. Faulty toothbrushing technique is one of the causes of gingival recession and tooth abrasion. The patient that use the horizontal technique other than the modified Bass technique may present with the gingival recession. So the instructed one is soft toothbrush and modified Bass technique. We have high frenal attachment. The frenum pull continuously throughout the movement of the lips and cheeks. It will lead to movement of the gingiva downwards, causing an apical shift and gingival recession. Also, excessive occlusal force may cause gingival recession throughout compressing the periodontal ligaments, and sometimes the malposition of the tooth. Throughout the excessive force, it will cause malpose tooth and thinning of the bone surrounding the root of the tooth and thinning of the gingiva, and as a subsequent leading to gingival recession. Also, tooth malposition, as we talked about, recession is influenced by the position of the tooth in the arch, also by mesiodistal curvature of the tooth surface. And sometimes the angle of the root in the bone is also affecting the thinning of the bone surface, the bone that covering the root surface, and also the gingiva, leading to gingival recession. Also, a thin gingival biotype here is different from the thick gingival biotype. This is more susceptible for gingival recession, more susceptible for minor trauma and bacterial invasion. Another cause is wrong habit and desires like nail biting, tongue piercing, and lip piercing. These minor traumas throughout time, with the presence of bacteria, it will cause gingival recession. And also dipping tobacco, despite its systemic effect, dipping tobacco is one of the causes, plus smoking, as we know, are one of the causes of gingival recession. Another cause is scurvy or vitamin C deficiency. It will lead to thinning of the gingiva and subsequently leading to gingival recession. And finally, and least powerful cause, and this is the least powerful cause in the causes of gingival recession, which is surgical exposure of the tooth. The improper technique may lead to gingival recession in these cases. So this is regarding the causes of gingival recession. Symptoms. We have three clinical significance in the gingival recession. One of them is root caries, when we have a root caries here. Throughout the gingival recession, the root will be exposed and it will be more prone to plug accumulation and formation of caries. And also the exposure of a dentin throughout a wearing of cementum that covering the dentin of the root. It will make the root surface or the tooth as general susceptible to different stimuli, including chemical stimuli, thermal stimuli, or air stimuli, and cause a tooth sensitivity, which is a painful condition. And the third clinical significance is that the interproximal recession creates an oral hygiene problem, causing plug accumulation and progression of the disease. present disease. So these are the clinical significance related to the gingival recession. And finally, we have a management. In the management, we have two main managements. One of them is gingival grafting. Throughout free gingival graft, we take an epithelium from the palate when we have not enough amount of keratinized tissue, and we just graft it here or at the site of the recession. And if we have a deficiency in the connective tissue, we have a good epithelium, but we don't have an enough connective tissue. So we take from underneath the epithelium, the keratinized epithelium of the palate, we take the connective tissue and we just graft it here at the site of the recession. And this is subepithelial connective tissue graft. This is the free gingival graft, and we have a synthetic one, which is called alloderm or acellular matrix connective tissue graft. When we just have a lack of connective tissue, we can use these ready-made grafts and just graft it to the side and leave it to heal. The more advanced one, we just use a growth factor technique. We take the blood from the patient and creating PRF or platelet-rich fibrin and just graft it to the site of recession. And sometimes we just use this with the bone, the plasma with the bone, or the platelet-rich fibrin with the bone, and use it on the receded area if we have, for example, a bone loss and soft tissue loss. And this is a great technique for restoring the receded gum and sometimes the bone. Thank you for your listening. This is my end of the lecture and the end of talking about the gingiva. I hope you get benefit from it, and thanks for your listening.